Welcome to the Deep Dive, where we take complex research and turn it into knowledge you need, and fast. Today, we're getting into the computational revolution that's happening in oncology. Our mission is to really structure and synthesize these cutting-edge ways that artificial intelligence and machine learning are transforming diagnosis, detection, and prognosis for two major cancers: breast cancer, or BCA, and bladder cancer, BCA.
And this is so essential. I mean, for anyone in medicine or even just learning about it, the stakes are just incredibly high. All the sources we analyze really confirm it. Early detection is the single biggest predictor of a good outcome.
And the numbers are just staggering.
Yeah, for localized breast cancer, when you diagnose it early, the survival rate can hit, what, 99%?
99%. I mean, that statistic alone is such a powerful argument for leveraging every single piece of technology we have.
Yeah.
AI isn't just a useful gadget here. It's becoming essential for getting over these fundamental barriers. Like, we're talking about tackling issues with X-ray mammography sensitivity, especially in dense breast tissue where human interpretation can be, well, really difficult.
It really boils down to two core needs. First, you have to reduce the subjectivity and, frankly, the labor involved in manual analysis. Pathology reports, image interpretation. And second, and this is increasingly important, is just handling the sheer scale and complexity of modern biomedical data.
Right. It's not just images anymore.
No, it spans everything from radiographic images to these incredibly detailed molecular fingerprints. And we're going to walk you through the methods being used across that whole spectrum.
Okay, so let's start where diagnosis has always begun. The traditional benchmark, which is histopathology. This is the definitive diagnosis, right? The microscopic study of biopsied tissue, usually with that H&E stain.
Right, hematoxylin and eosin.
Yeah.
And historically, a pathologist sits there looking at that slide for potentially hours, just quantifying visual signs of disease. It's time-consuming, it's laborious, and it can be pretty subjective. You get variability between labs, between clinicians.
So the goal for AI here is to automate that recognition of the microscopic markers that, signal that something is malignant. So when a human expert looks at that slide, what are those specific characteristics they're trained to spot? The ones AI systems are now learning to see digitally.
Well, there are four classic signs. Pathologists look for a poor resemblance to the original tissue, a loss of what's called basal polarity.
Meaning the cells are just not lined up correctly anymore.
Exactly. They've lost their ordered orientation. Then there's the presence of atypical mitotic figures, which shows the cell division is just fundamentally flawed. But maybe the easiest one to visualize is the increased nucleocytoplasmic ratio.
Okay, let's pause on that ratio. That's a perfect concept to ground for a moment.
Sure. Think of a healthy cell as a really well-organized factory. The nucleus, that's the control room, and it takes up a small part of the total floor space. In a cancer cell, that nucleus just swells. It becomes hyperactive, it's replicating like crazy, and that control room expands dramatically, maybe taking up 70 or 80% of the whole factory. That increased ratio is a critical, visible sign of malignancy.
And to standardize detecting these markers, we saw this brilliant hybrid system called AutoBreast. It's a fully automated pipeline for breast cancer diagnosis that actually combines deep learning with conventional machine learning.
Yeah, it's a great case study in what we call computational fusion. It processes the images through 4 stages: cleaning the image, extracting features, reducing the data, and then finally the diagnosis. And critically, it doesn't just rely on one type of feature extraction.
Can you break down those 3 feature sets they combined? This really gets to the heart of why that hybrid approach is so successful.
Absolutely. So the first set of features came from deep learning, specifically a network called ResNet-50. This network automatically learns these massive global patterns in the image that, a human might just miss.
Okay, so that's the big picture. What was the second set?
The second involved wavelet packet decomposition, or WPD. This is basically an advanced texture analysis. Think of it like tuning an equalizer to find specific visual patterns and frequencies in the cell structure.
So WPD gets texture and frequency. What about the third one?
The third was histogram of oriented gradients, or HOG. And HOG is fantastic for local, very specific features. It captures the edges, the contours, the shapes of the cell nuclei.
So you're fusing all 3, the global insight from deep learning, the texture from WPD, and the specific edges from HOG.
Exactly. And by fusing all 3, they created this incredibly robust data set.
And the performance, it speaks for itself. On the break-ins data set, When they fused all three and used an SVM classifier, they hit an accuracy of 97.56%. That insight, that AI is often most powerful when you combine that broad perception with detailed verification. That's a critical takeaway for you as a learner.
It really is. It shows that combining the power of DL to find new abstract features with traditional ML's ability to use human-defined features. Now, that's the peak approach right now.
Okay, so we've started at the cellular level, zooming in with histopathology. Let's zoom out now to the organ level. Let's look at these cutting-edge imaging modalities and the quantitative data they generate. And here we come across photoacoustic imaging, or PAI.
PAI is a fascinating emerging modality. It's non-invasive, and it's a huge leap forward because it combines the high contrast you get with optical imaging, with light,
Right.
with the deep tissue penetration of ultrasound.
So what critical functional information does PAI give us for breast cancer that, say, standard mammography, which is mostly structural, often misses?
Well, PAI provides functional imaging. It maps blood distribution and dynamics because hemoglobin has a really high optical absorption. This lets it identify malignant lesions based on two key things: tumor-related angiogenesis.
Which is the formation of all those new, chaotic blood vessels.
Exactly. And hypoxia, which is the low oxygen environment created by that rapid, chaotic growth. These are crucial biological signs of an active malignancy.
But if we want to turn PAI into a reliable quantitative tool, QPAI, we hit this problem, the light fluence correction problem. Why is that so hard to solve manually, and how does AI get around it?
The problem is that when you shine light into tissue, the light scatters. It dissipates unevenly as it goes deeper. So if you're trying to measure blood oxygenation, or SO2, you need to know exactly how much light actually reached your target. And manually accounting for that uneven scatter is just computationally exhaustive and often unreliable.
It's like trying to measure the brightness of a street lamp, but your sensor keeps moving and the air keeps getting thicker.
That's a perfect analogy. Deep learning networks are used specifically to model and overcome that scatter. The AI effectively calibrates the lighting conditions digitally. This allows QPAI to accurately translate those multi-wavelength images into quantitative maps of SO2. And since that blood oxygenation level is a direct indicator of malignant metabolic activity, this is a massive advancement.
Okay, so shifting gears a little. If PAI gives us functional characteristics, then radiomics gives us quantitative structural characteristics from images we already capture all the time, right?
That's exactly right. Radiomics is the discipline of extracting these high-throughput quantitative features biomarkers from standard images: mammography, MRI, ultrasound. So instead of a radiologist just subjectively describing a tumor as irregular, radiomics uses AI to quantify those features into measurable scores.
Now, what are the main morphological differences between a benign and a malignant tumor that radiomics is designed to quantify?
For you as a learner, just remember the classic clinical differences. Benign tumors are typically smoother, they have well-defined margins, they might be mobile. Malignant masses, on the other hand, are typically hard, they're fixed to the tissue around them, and have these highly irregular, jagged margins.
And the AI's value isn't just quantifying the obvious stuff.
Critically, no. AI systems are indispensable for spotting hard-to-find things like microcalcifications or very subtle masses, especially in dense breast tissue where the contrast is low. This means instead of a junior resident saying a tumor is suspicious, the AI gives an objective, measurable score. It really raises the standard for diagnosis and for training the next generation of clinicians.
Okay, so that covers the visual evidence, from the cell up to the organ. Now, let's dive into the fundamental molecular characteristics. We need to move beyond pixels and look at the engine running the cancer, the omics revolution, starting with metabolomics.
Right. Metabolomics is all about analyzing the profile of small molecules, or metabolites, in biofluids, blood, urine, whatever. Since metabolites are the end products of cellular processes, their profile gives us an immediate snapshot of the signaling pathways that are active. It's like looking at a factory's waste to figure out what it's making.
And this has a really powerful application in non-invasive screening, specifically for bladder cancer, BCA.
Yes. For BCA, the dream is a non-invasive urine test. One study focused on filtering metabolite profiles from the primary energy pathways, glycolysis and beta oxidation, which cancer cells just rely on so heavily. They were able to narrow down the signature of BCA to just 12 significant metabolites, including things like carnitine, pyruvate, and succinate.
Using only 12 molecules to predict cancer.
Yeah.
That sounds almost too simple. How powerful was the model trained on just that small profile?
It achieved a sensitivity of 91.3% and a specificity of 92.5% for BCA prediction.
Wow.
It just shows that analyzing these specific underlying metabolic shifts gives you a highly effective, non-invasive fingerprint for the disease. It gives you an objective molecular signature.
Which brings us to what I think is the most critical challenge in modern oncology: intratumor heterogeneity, or ITH. This is why single-cell omics is so vital.
ITH means that the cancer cells within a single tumor are genetically and phenotypically different. You're not fighting one enemy, you're fighting a diverse crowd. And this variability is why treatment selection is so hard. If a drug kills 95% of the cells, but the remaining 5% were already resistant.
Then those 5% will just repopulate,
Yeah.
the cancer comes back.
Exactly. You get recurrence.
And single-cell sequencing gives us the highest resolution possible to track these individual differences. What was the really profound insight this technology gave us about drug resistance in breast cancer?
By analyzing longitudinal samples, so biopsies taken from a patient before and after chemotherapy, the researchers found something incredible. The drug-resistant genotypes were often pre-existing.
Pre-existing, so they weren't mutations that were acquired in response to the drug.
No, they were rare clones that were already there and already inherently resistant. The chemotherapy just killed off all the susceptible cells, essentially selecting for the survival of the resistant ones.
That just fundamentally reframes how we have to think about initial treatment. It means we have to try to identify those pre-existing resistant clones before we even give the first dose of chemo. If you know the biggest bullies are already in the back row, you need a strategy to hit them first.
Absolutely. And this pushes us toward the future goal of multiomics analysis, integrating the genome, the transcriptome, the proteome, the epigenome, ideally all from the same single cell. That level of integration is the only way to create a truly comprehensive map of the whole tumor ecosystem. That's how we get to true precision medicine.
So if we connect this all to the bigger picture, for you as a medical learner, it's crucial to understand the computational toolbox that's driving this. Let's talk about the algorithms themselves.
Well, we see a clear division between what we call traditional machine learning and modern deep learning. Traditional ML, things like support vector machines or random forests, they rely entirely on feature engineering.
Meaning a human expert has to define what the algorithm should look for: texture, shape, color statistics.
Exactly. The human defines the features, the algorithm just classifies based on them. And something like random forest is popular because it's an ensemble method. It combines many weaker classifiers to reduce overfitting.
But then deep learning came along.
Correct. Deep learning, primarily through convolutional neural networks, or CNNs like ResNet or VGG16, it revolutionized image analysis. DL networks overcome all that manual labor by automatically learning the most relevant global features directly from the raw data. They learn what the features are while they're classifying.
And we often see architectures like UNet cited in medical literature. What's its specialized role?
UNet is dominant in medical image segmentation. So where ResNet might classify a whole image as cancerous, UNet is designed to meticulously outline the exact boundaries of the tumor or segment individual cell nuclei, which is absolutely crucial for things like treatment planning and radiation therapy.
And to evaluate how well any of these work, we need standardized metrics.
Yeah.
But hold on, why do we always talk about sensitivity and specificity in cancer diagnosis instead of just, simple accuracy?
That is a critical question. Accuracy is the overall correct rate, but in medicine, the costs of error are not equal. If we have high accuracy but low sensitivity, we might be missing actual cancer cases, false negatives, which is a disaster.
Right.
So sensitivity, the true positive rate, measures how well we identify all the cancer cases. And specificity, the true negative rate, measures how well we correctly identify healthy patients, avoiding unnecessary follow-ups.
So you need both to be high, but you usually prioritize sensitivity to avoid missing the disease.
Precisely. And the area under the curve, or AUC, is the gold standard for summarizing a classifier's overall ability to distinguish between the classes. An AUC between 0.8 and 0.9 is excellent, above 0.9 is outstanding.
So given all this phenomenal success, why isn't AI fully implemented across every single oncology department? What are the big challenges?
The primary hurdle is data. Specifically, the lack of large, standardized, multi-institutional data sets. An AI model trained perfectly on one hospital's machines might fail spectacularly at another hospital just due to differences in image protocols or demographic bias. This is a huge issue for MRI and PET.
So standardization is lacking. What's the second data-related challenge?
Imbalanced data. Training data often has way more examples of normal tissue than cancerous tissue. If an AI is trained mostly on healthy examples, it can develop a bias. It gets really good at saying, no, this isn't cancer, but becomes less reliable at identifying that rare positive case.
And finally, the integration challenge. The future isn't just one algorithm looking at one image.
No. For true personalized medicine, future models have to incorporate and integrate all the data modalities, not just the image pixels, but the radiomics features, the genetic info, the patient history, all the molecular data we discussed. Only that kind of multimodal integration will give us the robustness we need for these really complex, personalized treatment decisions.
This has been a fascinating journey through the front lines of computational oncology. We've covered how AI enhances histopathology with models like AutoBreast, how advanced imaging like PAI maps functional characteristics, and how the molecular revolution is revealing metabolic fingerprints and single-cell details.
The ultimate takeaway for you is that AI is quickly moving toward making diagnosis faster, less subjective, and just far more accurate. It's about using these algorithms to create prognostic models that guide personalized treatment, which, at the end of the day, leads to better patient outcomes.
Which brings us to our final provocative thought for you to think about. We learned from the single-cell omics data that drug-resistant cancer cells are often pre-existing. They were there before treatment even began. So if clinicians know, through better diagnostic screening, that their patient's tumor already contains these genetically diverse pre-resistant clones, how does that knowledge fundamentally change their approach to initial treatment planning, to drug combination selection, and to long-term surveillance for cancer recurrence? Think about how knowing the enemy is already heterogeneous impacts that very first strategic move you make.